This project came about through my practicum work at the Healthy Public Policy Unit at Alberta Health Services, in which I identified the policy that I'm going to present as an evidence-based, cost-efficient, and healthy public policy approach to the crisis. In March 2000, good. Is that better? In March 2017, as luck would have it, this policy actually came into effect. And while advocacy of the policy is no longer needed, my analysis still provides opportunity to highlight some of the key impacts of this policy, as well as some of the potential unintended consequences. So, opioids have been around for centuries, and currently Canadians are using a lot of them. Opioids are pain-relieving substances that act on opioid receptors in the brain and in the spinal cord. Many opioid addictions start out as prescriptions for legitimate pain. Opioids can be prescribed or illicit, and along with pain relief, they can cause feelings of pain relief and sedation. They also have the characteristics of tolerance and physical dependence, meaning that over time, people need to take more and more of them to get the desired effect, and that if you stop taking them, you can experience unpleasant withdrawal symptoms. In high amounts, opioids can cause people to stop breathing and die. Many people who become addicted to opioids need help to stop taking them. Fentanyl is 100 times more powerful. Sorry. Sorry, guys. Okay. So a highly significant issue in and around the opioid crisis is the recent surge in fentanyl use across Canada, and particularly in BC and Alberta. Fentanyl is 100 times more powerful than morphine, and overdose is common. The increased availability of illicit fentanyl has exacerbated the public health crisis and the need for a public health response. Part of the multi-pronged strategy to deal with the opioid crisis is to expand access to treatment or opioid replacement therapy. So what is ORT, and how can we do that? To combat opiate addiction, opioid replacement therapy, or ORT, is used. This is the prescribing of controlled amounts of longer-acting opioids that have less euphoric effects and help reduce cravings and prevent withdrawal symptoms. Previously, ORT has been restricted to highly regulated and controlled treatment settings because prior to 2007, methadone was all we had to work with. Methadone has very high abuse potential and many safety concerns, and while Suboxone is much safer and can be prescribed in a more flexible way. Despite the availability of Suboxone, ORT in Alberta anyways, has remained largely confined to addiction specialty clinics in urban areas, and in 2016, most of these clinics were operating at or above capacity, and we had lengthy wait lists as well. One of the reasons for this may be that previously physicians were required to complete mandatory training at a cost to themselves so that they can, and seek approval from the College of Physicians and Surgeons before they could prescribe Suboxone in their practice. In 2016, only 2% of physicians in Alberta were eligible to prescribe. So, just to recap, the policy that I analyzed is the elimination of these authorization requirements. Before getting into the policy analysis, a few words on harm reduction. Harm reduction refers to the policies, programs, and practices that aim to reduce the negative health, social, and economic consequences related to legal and illegal drug use without necessarily reducing use. Its cornerstones are public health, human rights, and social justice. I believe that any meaningful policy analysis, any meaningful analysis of public health policies that are intended to address substance abuse in Western society must be done through a harm reduction lens. Public policies that are designed to eliminate drug use by controlling behavior rather than addressing the social, economic, and political conditions that shape vulnerabilities to drug use in the first place generally fail to achieve their primary goals and sometimes exacerbate some of the problems that we intend to reduce, such as violence, crime, and addiction. Okay, so the analysis. I chose to use the National Collaborating Center for Healthy Public Policies framework for analyzing public policies for a couple reasons. A, this framework is specifically developed to analyze public health policy, and B, it offered a more comprehensive, thorough approach than some of the other frameworks I looked at. Additionally, it came with online training course and lots of additional resources to help me complete a more comprehensive analysis. With this framework, as you can see, public policies are examined by looking at effects and implementation. When we look at the effectiveness, we want to know how effective is the policy in achieving its primary objective, in this case, increasing access to ORT. So we can look to other jurisdictions to predict effectiveness here. In 1996, France removed prescribing restrictions on Suboxone in response to an HIV endemic and saw a marked increase in access to ORT, as well as improved health and social outcomes as a result. These changes were accompanied by a 79% decrease in deaths related to opioid overdose. Conversely, down in the States, Suboxone has been used primarily in office-based settings to begin with, rather than in addiction clinics. And while this approach has been effective at reducing barriers to treatment and has increased capacity, compulsory education and authorization requirements remain in effect, and so rates of access and the number of prescribing physicians remain relatively low. Most policies also create unintended effects that are distinct from the primary objective. Unintended effects can be positive or negative, and identifying them provides us with an opportunity to correct or mitigate them. The literature identifies many of the possibilities or many of the effects listed here, but probably the most concerning is the potential for increased diversion and abuse. Increased prescribing of Suboxone is almost always paralleled by increased diversion. Diversion is the act of giving or selling medication to someone other than to who it's prescribed for. And we know that strict regulations and efforts to control diversion are usually not effective to prevent it. Suboxone does have abuse potential, meaning it can be sought after and used as a drug of abuse. In France and Finland, Suboxone is the most abused opioid, but let's recall that this increase was also accompanied by a 79% decrease in overdose deaths. Furthermore, some of the research has shown that the majority of illicit Suboxone use is being used therapeutically to manage withdrawal and or addiction, and that unavailability of a prescribing physician was cited as the reason. Although public health policies are usually intended to improve overall population health, they can have differential and undesirable impacts on diverse groups and widen gaps in health equity. This policy assumes that everyone has equal access to a family physician, and we know that's not true. It may not have a strong impact on people who already have underlying barriers to health care. Many people in these groups here face multiple barriers to health and still will require targeted efforts to support health equity. Let's take a quick look now at implementation issues, cost, feasibility, and acceptability. This policy had no upfront costs, and ORT is well known to have positive financial as well as individual and public health outcomes. One study estimated a $76 return on every dollar spent when reduced criminal activity, justice system, and healthcare costs were taken into account. So overall, over time, this should generate good cost savings. So after going through this analysis process, I found that while there were some drawbacks to this policy, such as increased diversion and abuse, they were outweighed by the positive benefits such as increased treatment capacity and decrease in the number of overdose. In conclusion, I recommend this policy option of removing the authorization requirements to prescribe Suboxone as a helpful harm reduction strategy to address the opioid crisis in Alberta, while still suggesting that additional work is needed to ensure that all groups benefit from this policy, that certain groups don't bear a greater burden of the potential negative impacts, as well as to support physicians in a safe, effective treatment of opioid dependence. And a quick thank you to Alberta Health Services, Healthy Public Policy Unit, my supervisors, Delane and Michelle, University of Victoria, and my first and second readers, Karen and Nigel. Thanks.
Thank you very much. Again, an excellent talk.
Okay.
Some questions.
That was a really interesting presentation. I really enjoyed listening to that. I'm sure many of us did. Coming from a background of working frontline in the treatment setting, I know a lot of clients who have gone on Suboxone, they've had a lot of withdrawal symptoms and whatnot, and I feel like unless like an MD who's prescribing this has the proper training and have the wraparound supports to actually support them, then the success rate of them reducing their dosage or completely becoming clean increases. I'm just wondering if that's specifically within your recommendations of those wraparound services such as social workers, for example.
Right. That's complex. It was part of my recommendations that we support physicians in safe prescribing practice, because one of the other things that happened in France is they also found that physicians were not prescribing according to guidelines, and that's problematic in itself. So a good strategy, and the College of Physicians and Surgeons in Alberta has multiple resources on their websites that they are guiding physicians to use to provide safer, more effective care. So hopefully we can mitigate most of those issues before they happen.
Thank you.
Mm-hmm. Oh, yep. Oh, that's all right. I like the exercise. Thank
you. Did you look into any, I guess, protocol, or was there any, I guess, literature, interest, whatever, in teaching directly to medical students about Suboxone?
Yeah, that was also identified in my, not just medical students, but nursing students as well. So one approach to providing better care to this, or to this large group of people that use opioids and aren't currently getting care, is to teach nursing students and medical students in school. Yeah.
It's just time for one more question.
Hi, Tacie. That was awesome. That was a lot of complex information. I know that's all complicated. Similar question to Chase. When you were looking at the other models in France, was like in some of the negative side effects, was there anything about increased overdose or fatalities because people were coming off Suboxone or methadone because it wasn't properly prescribed? Because I know that has been an issue that we're concerned of with people coming off of or relapsing from those treatments, which then they are more vulnerable to overdose. So I think it's a great, I'm not debating you by any means, I think it's awesome, but I was just curious if you found that in the other models that you looked into.
Yeah, definitely that's part of safe and effective prescribing practices, is not to cut people off and to use a harm reduction lens to behaviors in medical practice. So not cutting people off for diverting or, not being compliant with the specific treatment plan, but absolutely that's a potential, and it very much depends on the environment. So in France and Finland, the most available opioid of abuse is Suboxone, so they're probably not as risk for overdose if they relapse there. But here, that would be a different issue, right? Mm-hmm.
Again, thank you very much, and thanks for some really good answers too.